So, good evening, everyone. This is I welcome you everyone for this 18th iStent forum here in India, and we are actually going to have two eminent speaker along with us today. And I am actually based in Calcutta, looking after the business for Glaucos here in Calcutta, looking after the entire eastern region. And now I'm going to introduce our moderator for today, Dr. Devashish Chakraborty, who will be subsequently introduce our both the speakers. And we will continue the session for next 1 year. So I hope the next 1 year session will be very exciting, and it will be very enriching knowledge for all of you, because here we will be discussing most of iStent procedures, technology, skill development, and the complications as well. So we'll be having two consecutive speakers will be speaking on different topics, and then we'll have a question and answer session. The entire session will be moderating by Dr. Devashish Chakraborty, none other than Dr. Devashish Chakraborty, who is a eminent senior glaucoma specialist here in Calcutta. He's working in Center for Sight as a senior consultant. Dr. Devashish Chakraborty has completed his long-term glaucoma fellowship at LV Prasad Eye Hospital, Hyderabad. Currently, he is working as a senior consultant and in glaucoma and cataract at Center for Sight at Calcutta. With this small introduction of Dr. Devashish Chakraborty, I am now handing over the mic to Dr. Devashish Chakraborty to introduce our speaker and take this event next in couple of hours. Over to you, Dr. Chakraborty.
Right. Thank you, Mr. Shutanoy, and thank you for organizing such an educational event. I think we'll all benefit from this. Although it's a new technology, relatively new technology, but it is gradually becoming popular. And I think our speakers will highlight what are the initial hindrances they face in this new technology. So we have two very eminent speakers today. First of all, I will introduce Dr. Preveen Kumar, and I know him since LVP days. So Dr. Preveen Kumar has an exceptionally good educational background. He did his MBBS from Grand Medical College, Mumbai, and then his MS in ophthalmology from JIPMAR, Pondicherry. And then he was a senior resident in JIPMAR, and then he finished his long-term glaucoma fellowship in LV Prasad Eye Institute, Hyderabad. And currently he's a senior consultant in glaucoma and cataract at Center for Sight, Patna. And we also have with us Dr. Aditi Pochar, who again is a very senior glaucoma specialist, and she had done glaucoma fellowships both in India as well as abroad in Singapore. And she is extensively doing glaucoma surgeries and cataract surgeries. And she's also a senior consultant in Center for Sight, Delhi, I think, no? Dr. Aditi?
Yes.
Yeah.
Yes, sir.
Yeah. Okay.
Yes.
Right. So welcome to both our speakers. And let's hope that you will throw light on the new technology and how to overcome the initial obstacles that anybody will face in implanting this device. So the first talk will be given by Dr. Preveen Kumar, and his topic is my initial experience with iStent Inject W. So over to you, Dr. Preveen.
Hope my slides is visible, and am I audible now?
Yes, you are.
Hello?
Yes, Dr. Preveen, you are. Yes, you are visible and audible.
Okay. So good evening all. I think this is going to be a wonderful evening with a nice academic feast with all the eminent people. So definitely the iStent is a new technology, and science in the lab, coming science from the lab to the clinic, and from the clinic to the operation theater. Definitely there will be there is a time lag, but with all the evidences, literature, consulting the mentors and your friends, sometimes these hurdles we may overcome. And since my PG days, we were preparing the topic for MIGS, and and I am very fortunate enough to performing MIGS, and recently I performed two eye stent surgery. So definitely this 1 minute slides is not moving. Learning is a definitely a continuous process. So as Albert Einstein has said that if you are stopping the learning, then you are almost going to die. So when we are looking for the development of medical management of glaucoma, it was since 1877 when the pilocarpine was discovered, and nowadays we are featuring towards the intraocular implants of the bimatoprost. In the similar way, glaucoma surgery, as we all know, trabeculectomy is still the gold standard, and it was first performed by Cranes in 1960s. And since then, not only in the trabeculectomy, surgery has evolved so much with the use of releasable suture, adjustable sutures, use of antifibrotic agents like mitomycin and 5-fluorouracil. But other glaucoma surgeries has evolved so much, and recently, since the last 2 decades, there is significant paradigm shift in the management of glaucoma in the form of MIGS. And in MIGS includes GAT, trabectome, Kahook dual bridge, that is KDB, and BANG and iStent. So minimally invasive surgery is definitely different from the traditional glaucoma surgery, that is trabeculectomy, because it is ab interno, it is conjunctival sparing with small incision. There is very minimal tissue disruption and minimal tissue trauma. There is high safety profile. There is rapid visual recovery, and it can be combined with a cataract surgery, and it is very ideal for the moderate glaucoma with high IOP. So mechanism of this MIGS or iStent, it is bypassing the obstruction from the trabecular meshwork. By implanting this iStent, it is basically bypassing the resistance that is offered by the trabecular meshwork, and then this aqueous humor will flow through the canal of the iStent to the Slem's canal, and from the Slem's canal, it will go to the collector channel, and thereby it is controlling the IOP. When I decided to perform the surgery, so the first step about the patient selection. So before planning any surgery, recent new surgery, so definitely there will be a mind hurdle whether this surgery will work or not, what literature is saying, what my seniors and mentors and my friends are saying. So definitely I referred various literatures, and when I found, yes, there is a good outcome with good safety profile, and when I consulted my mentors, my seniors, everyone was giving a positive response. Then I decided to perform the surgery, and it was in my mind since last 1 year, but somehow it was not worked up. But when I decided, so definitely the patient selection is very important thing. So first, the patient should have mild to moderate glaucoma, angle should be open, and there should be a IOP up to 30 millimeter of mercury with the medicine, and we should have the target IOP in the mid to higher teens. Patient should be phakic, can be pseudophakic. Patient may have difficulty in instillating the eye drop, because so many of the glaucoma patients are age old because of the tremors, and if someone is not available in the family to put the drop, so it is very difficult to those patients to instill the drop. There may be the side effect related to the preservative in the AGM or anti-glaucoma drops, or there may be the side effect associated with the drops, like usually we are seeing with the brimonidine, like toxic or allergic reactions. Patient may have poor compliance because of the various region, because of unavailability in the peripheral part of the India, because of the cost issues. So patient may have the poor compliance because of all these reasons. So angle anatomy should be normal and open, and there should be absence of peripheral anterior synecdoche, but it can be handled if there is a very small peripheral anterior synecdoche. So, with the various classification of the severity of the glaucoma, so most commonly accepted or most commonly clinically planned classification of the severity of glaucoma is based on the mean deviation. Less than 16 decibel is considered as mild. 6 to 12 decibel is considered as moderate, and 12 to 20 decibel is considered as severe, and more than 20 will be very severe. So, according to this criteria, we have to plan for the mild and moderate glaucoma only. So, basically, as I told, ki mild and moderate glaucoma, we should perform, ideally, we should perform this eye stent surgery. So, our target IOP should be at least reduction up to 30% of the IOP. There will be reduction of not only the IOP, but also the number of drops patient is using, and definitely halting the progression of the glaucoma. And I want to include the quality of life as well, because if we are making those patients AGM free, definitely there will be the very high improvement of the quality of life in those patients. So there is big meta-analysis on eye stent by Gilman and Hornbeck, which has included almost 1100 eyes, and which has shown there is significant stoppage of the progression of the glaucoma over the year. Although they have shown around 13% progression of the glaucoma even with this, but there is significant reduction of the IOP, that is up to 42%, but average mean IOP reduction is 26.6%, and also there is significant reduction of the anti-glaucoma medication. And also with the old MIGS surgery like CyPass has been withdrawn from the market because of the significant reduction of the endothelial cell count, and that's why it is withdrawn from the market. But iStent, there is very, very minimal or clinically insignificant effect on the endothelium by this procedure. So it can performed alone, or it can be combined with the cataract surgery. So what are the challenges while doing the eye stent implantation? As I discussed, how we should select the patient, and intraoperatively or in the OT, definitely there is challenges for the visualization of the angle, and definitely while the implantation. So visualization of the angle, I think we should practice even in the normal patients before going for the eye stent. So there should be an en-face view of the microscope to the eye. So we have to tilt the patient head away from us up to 30 to 40 degree, and there should be tilting of the microscope towards us up to 30 to 40 degree. So there will be the one line view from the eye to the from surgeon's eye to the patient's eye, and we need to use the gonioscopy. I commonly use the eye prism SX and the Swan Jacob lens, but the advantage in eye prism SX is there it is providing the wider view of the angle intraoperatively. So this is I think most important step while performing the surgery, visualization of the angle. So this is the basically the eye stent injector W, which involve the this one is the sleeve retractor. This one is the stent delivery button, and this one is the sleeve along with the trocar. So while implantation, we have to use this sleeve retractor to retract the sleeve to expose the trocar. And in this trocar, there is two loaded eye stent, and when we touch the trocar to the trabecular meshwork, then we have to make a nice dimple to the trabecular meshwork. Then subsequently, from this delivery button, we have to push. So by this way, we need to inject the eye stent in the trabecular meshwork. So this is the my video of my first surgery. So before playing the video, I want to explain about the patient clinical profile. patient was having on follow-up with us since last 4 years. Patient was ocular hypertensive with borderline high IOP with 4 medication around 22 to 23. But last month, patient developed a few visual field defect. So we have planned for this patient iStent. And so So clear corneal incision was taken. This should be slightly towards the cornea because minimal insult to the conjunctiva may cause bleeding and that may obscure the visualization of the angle. Then we have to inject the high viscous OVD 1.8 sodium hyaluronate, and this is the eye prism SX for the better visualization of the angle. Here we can see the blood in the Slim's canal, and this is the, I think, good sign to visualize the angle. Then then I inserted the eye inject stent into the anterior chamber, and subsequently after the this is the basically not a good implantation, uh, and it is basically the under implantation. So I left this one as it is, and I injected the second eye stent in the other quadrant, approx 2 clock hour away from the first. Then after and this is the second eye stent injected into the trabecular meshwork. We can see the very nice dimple in that area, and then we will click, and we can see the slightly blood oozing of blood is a good sign. Then this under implanted eye stent I explanted, and I reloaded in the trocar. So this is in the OVD 1.8 hyaluronate, sodium hyaluronate. And after loading this eye stent in the trocar, I implanted this eye stent slightly away from the previous one. Yeah, this is the dimple and then the injection of the second implant. So I checked with the dialer. The stability of the eye stent was checked, whether it is implanted nicely or not. And subsequently, the OVD was washed with the IA, and side port was hydrated. So this is my first case of the eye stent, and this is the and post-operative day one, patient was having IOP of 23. So in that fear, ki patient may have the some amount of OVD in the anterior chamber. So I just started the normal post-op regime along with the pilocarpine. And on first week, IOP was 18 without any AGM, without any topical AGM. For that patient was using before around 4 AGM. And at 1 week post-op, patient was without AGM with IOP of 18 millimeter of mercury. And this is the anterior chamber view of the eye stent. So the common intraoperative complication, there may be the malpositioning of the stent, whether it may be too deep or too shallow. There, the first eye stent implantation was of mine was too shallow, that I explanted and then I re-implanted. There may be the misplacement outside the Slim's canal. There may be obstruction of the eye stent because of the blood or iris or fibrin. So blood usually get washed out because it is heparin coated. Iris, to prevent the obstruction from the iris, we usually using the pilocarpine. And fibrin, that is basically the because of the inflammation. So it is very less likely, but post-operative topical steroid may resolve it. And there may be the failure of eye stent implantation because of the anatomical difficulty in presence of pus. So post-operative complication may be hyphema, which is usually self-resolving, and with the normal post-operative medication, it will get resolved. There may be transient IOP spike. As in my case, I cannot say it is transient spike, because pre-operatively patient was on 4 medication, and then the medication was stopped. And this post-operative, immediate post-operative spike may be related to the OVD. There may be inadequate IOP reduction. Subsequently, patient may be switch on to the anti-glaucoma medication. Although this complication is very rare, that is corneal endothelial cell count and inflammation because of the continuous rubbing of the iris tissue to the eye stent. It is also very rare, but the post-operative regime, that is steroid, will be very helpful to control the uveitis. So post-operative regimen is the normal one. Prednisolone acetate eye drop 4 times a day in tapering dose weekly. One tier substitute along with the antibiotic, and iotim plus. Iotim plus is basically a combination of iotim, that is timolol, along with the pilocarpine. Pilocarpine is basically to stretch the tissue, stretch the iris tissue and pull the iris tissue from the angle to prevent the obstruction of the eye stent from the iris tissue. And follow up usually 1 day, 7 days, 1 month, and third month, and each follow up gonio and AT should be done. So to conclude, MIGS is definitely emerged a promising approach to address unmet need in the glaucoma management. What I wanted to tell unmet need are because the conventional surgery is having, although trabeculectomy is gold standard and with very good surgical efficacious outcome, but it is associated with the complication. So high safety profile with good efficacy. It is very promising approach as in MIGS. It offer safer and effective IOP reduction in especially in the mild and moderate glaucoma, but still for the severe glaucoma, trabeculectomy is gold standard. And with time, all glaucoma surgery will evolve remarkably. So we are expecting more revolution in the field of eye stent also, as while reading the various literature. So I came to know that iStent inject W infinite is also coming up with in few years. So hope for the best and with good patient care. So thank you so much. So this was my personal experience with my first case of iStent.
Thank you, Praveen. Thank you so much, and congratulations to you because of the successful outcome of your first case. Can you please share your video once, because let us discuss some of the finer details that all of us face in the initial few cases. Only the video, yes, yes. So, Mr. Sutana, you are also there. No, you have seen so many of us
Yes.
doing our first iStent surgeries. And let's go step by step, and let's just reevaluate what are the problems which every surgeon faces while doing the first few cases. Praveen, can you start the video once again?
Video is playing, sir.
No,
No.
doctor, it is not playing.
1 minute.
Yes, we can see now.
So it is visible, sir?
No, no.
Wait. I'll reshare once.
Yes, you reshare that.
Is it visible, sir?
Yes, we are able to see the PowerPoint. Go back to the video slide.
Is it visible now?
Yes, now it's visible. Now it's visible. Right. Okay. So as Praveen has highlighted, the most crucial step is good visualization. So for that, this we have to practice it before we even venture into our first surgery. You have to practice visualization. So you tilt the microscope towards you around 35 degrees and tilt the patient's head away from you and get a good magnification. And as he had mentioned, you avoid any nick in the conjunctiva so that you get a pristine view of the cornea. Now, so this, Preveen, this was a phakic patient.
This is pseudophakic patient, sir.
This is a pseudophakic patient.
Yes,
Okay,
sir.
pseudophakic patient with ocular hypertension.
Yes.
And then who has started developing a few disc changes
yes,
and
sir.
field changes.
Yes,
right.
sir.
Okay. Okay. So yes. So in a usually we do either in a pseudophakic patient or we do a combined phaco and iStent, although we can do in phakic patient also. So sometimes if the pupil is slightly large or if the angle is not so wide open, you can also give injection pilocarpine to constrict the pupil and get a better view of the angle. So my first the first iStent inject is whether I will be able to visualize the angle properly. I had asked so many people what will happen if I'm not able to see the trabecular meshwork, if it is not pigmented. Then somebody suggested you give trypan blue, inject trypan blue. I had even started tried that and it helps. But in most cases, this beautiful picture of the blood in the Schlemm's canal will actually direct you to the exact location of the of where to implant. So the next thing is you have to retract the sleeve and see before even entering the eye, see whether the retraction mechanism is proper. That is whether the needle is properly retracting or not. So then you enter avoiding touch with the iris and the cornea. And this is the most important crucial thing. So this I think, Preveen, uh, had you tilted the patient's head a little bit away from you, probably would have got a better view, en-face view. Do you think so? Although this is quite good, but the proper en-face view.
Okay, it may there
If you
may be some.
slightly move it away from you,
Okay.
you get a very good en-face view, so that your device is exactly perpendicular to the trabecular meshwork, because a little bit of bias will make a slight tilt
Yes,
to the iStent inject, and it will not implant exactly perpendicular to the trabecular meshwork.
yes,
So
yes.
that is one thing. This is otherwise it is exactly in the right place. It is in the trabecular meshwork. Right.
Yeah.
So sometimes if it's a little bit of loose, you can just push it with the tip of the prober, and that will then will implant. But if it is angulated, then what you did is perfect. You just implant the second, and then you go back to this device, and then maybe you take it out and then reload. So I would request Mr. Sutanay to highlight that there are two more clicks, no, in a device. Even if it is loose, or if you feel that you have to reimplant it, there are two more clicks available in the device. Mr. Sutanay, just highlight this point.
Absolutely. I think, doctor, this is very important. So in every stent, every stent device, you have 4 clicks. It means there are 4 times you can click the device for the for the right implantation, and you have two
Praveen,
devices
just
to
stop the
implant.
video once. We'll go back to this point also.
So that's what. So we just want to say that there are 4 clicks. We have 4 options to implant to. So as this case also happened, the first stent that's not able to implant properly. So that's why you have 2 more clicks available if you want to do. So you have option of reimplant, rethread, and implant the stent if it is required.
Right. So you have two more chances. If you feel that even the second stent is not in the proper place, you can take it out, and you outside the eye, you can reimplant in the device, and then you can inject it again. So 4 clicks are available in all. Fine. Please, Praveen, please proceed with the video. Yes. So what he did rightly is he just is trying to yes, he is taking out this device, and then this is very important. This has happened to all of us, and it's good that it happens in the first few cases, so that we have confidence that if there is such a complication, we are able to manage it. So you have to put a little bit of viscoelastic on a white background, and then you have to reimplant this device. Yes, and this time he is exactly perpendicular to the trabecular meshwork, and just after you hear the click sound, immediately don't withdraw. you pause for a few seconds, or else the momentum will carry it along with the needle. So you inject, you see, you hear the click, then you wait for a few seconds and then gradually withdraw it. And then if a little bit of bleeding is there, of course you have to wash it out and be very gentle. Right. So Praveen, what are the challenges that you faced in this case?
Sir, first of all, doing a new surgery. So this is the first kind of challenge that I face, ki performing a new surgery and
Yes, mental pressure.
mental pressure and patient expectation, because this is not a kind of this is a kind of basically expensive surgery. So
Yes,
meeting that expectation with a huge cost, so there is no chance, there should be no chance of error. So that was the first challenge that I felt. And
right.
definitely the intraoperative challenges everyone has to face if we are planning to do so. So
Yes.
definitely before injecting this eye stent, I performed almost 10 to 12 MIGS surgery, bang or KDB. So with this all, the visualization challenge was significantly low that I felt when I proceed to the eye stent. So I think the main challenge, main intraoperative challenge is the basically the visualization of the angle. And also I did the case after giving the peribulbar block, because minimal movement in that high magnification will move that patient out of the focus. So that's why I think few cases, few 8 to 10 cases, I have to perform in the peribulbar block, so that the challenges given by the patient should not hinder the surgical outcome. And also the in the post-operative when I did the surgery, so I am very I am thinking myself as a fortunate enough to have this kind of malpositioning in my first case only. So that's why I explanted and I reimplanted. This is kind of learning we should, I think, should be in the few cases, in the few initial cases should happen, so that I should learn. And definitely post-operatively, when the patient has the borderline high IOP, so I was thinking whether the eye stent is working or not. So in that thinking that part, so I thought ki there will be some kind of some amount of visco maybe there in the anterior chamber. Then I caught that patient in the third week also. So after washing out the visco, luckily on that day, on third day, patient IP was 20, and subsequently on the 10th day it was 18. So, so if something there is in our mind, so it's better to call the patient slightly earlier to look for the better to look for the outcome, whether it is better or not. So I am thinking myself as a fortunate enough to got these kind of intraoperative challenge, that is malpositioning of the eye stent, and also with the good surgical outcome, and patient is willing for the other eye as well. So these all are the like giving the surgical pleasure to all of us if the patient outcome is along with the expectation of the patients.
Right. Yes, indeed. So this another challenge is the high magnification that you have to use. It's much higher than the normal. I actually do phaco in a much smaller, lesser magnification compared to other people because I feel more comfortable with it. I think it is better three-dimensional view. But with iStent, you have to actually visualize the needle and the two stents through that window. So that requires a very high magnification. And in this high magnification, a little bit of movement will actually distort the entire view. So very high magnification, and then you have to be absolutely still, and you have to visualize the needle entering the trabecular meshwork, and then create only a slight dimple, because I have a few cases where the dimple was more and I had exerted more pressure, and what happened is that it is over implanted. Although the eye stent is working, but when you do the postoperative gonioscopy, you feel that it's deeper inside the trabecular meshwork tissue. Although the flange is visible, but you can appreciate that it is deeper than what it should be. So only a slight, just visualize the needle touching the trabecular meshwork, only slight dimple, absolutely still hands. inject the black button, press the black button. You hear the click, wait for a few seconds, then gradually, without moving, just retract your hand. So once it happens in a few seconds, so those few seconds are very important. So excellent outcome, Praveen. Congratulations to you once again, and let's hope you do many more good cases. Okay,
Yes, sir.
thank you
Thank
so
you, sir.
much.
Thank you,
Okay,
sir.
okay. So our next presenter will be Dr. Aditi, and I would invite Dr. Aditi with her presentation.
Thank you so much, sir. Thank you so much. I'll just share my screen. Are you able to see, sir?
Yes, it is visible, doctor. It is visible.
Yes, yes. Thank you. Okay, so good evening, everybody. And sorry, one second. Good evening, everybody, and thank you, Glaucos, and thank you, sir, for this.
Doctor, 1 minute. Can you just make a full screen of the presentation?
Yes, sir. Yes, sir. Okay.
Thank you very much. Thank you.
Okay. Okay. Thank you, sir, for this wonderful opportunity. So I'll also be talking about my experience in iStent Inject G2W. So just before I start my presentation, just a positive note that every expert in anything was once a beginner. So I will be describing my learning curve, my technical challenges, and my progression of surgical proficiency from my first iStent to my current situation. So just to describe, Praveen sir has already described the iStent in detail. It is an ab interno micro bypass stent which helps to maintain physiological outflow. And this is just already explained by Praveen sir, so I won't go into the details of the type of inject and the injector. Again, the stent placement and approach. Yes, so I'll be talking about for the benefit of my juniors who are also here. I think my two fellows are also attending this particular talk. So, as Praveen sir already described, before we perform any mix, we have to have the proper positioning of the patient. The microscope should be tilted towards the surgeon around 35 degrees, and the patient's head is tilted away from the surgeon by 25 degrees. There are different type of lenses which are now available. So I prefer either the Swan Jacob lens or the iPrism SX, as Praveen sir also shared with us. Before the procedure starts, we need to inject a cohesive viscoelastic, preferably Helon GV. The use of a miotic is plus or minus depending on the surgeon preference, and the magnification, again, as sir also said, it should be on a very high magnification, at least 10 to 12x. So this is just a model video which I am going to share. This is a video by my mentor, Dr. Shamira Pereira, who is a chairman at SNEC. So I just want to share the basic, it's a very, because he's a very fast surgeon also, a very, just the, we get a gist of the kind of procedure that is done. Two stents which have to be injected into the trabecular meshwork at least 2 to 3 clock hours apart from each other. So I will be describing my G2W learning curve in in this particular presentation. So I have done approximately 24 eyes. The cases which I have done are combined cataract with MIGS, that is phacoemulsification with G2W. These cases were done from my fellowship period in SNEC to my current position at CFS New Delhi. The cases which I have performed belong to the mild to moderate POAG group, NTG, and ocular hypertension group. One case I performed was of severe glaucoma, and the patients have been who I have done have been on one or more anti-glaucoma medication. One case was a status post YAGPI who had open angles, whom I have injected iStent. All my phacoemulsification in all these 24 eyes have been uneventful. So the parameters which I assessed were the first attempt correct placement rate, the intraoperative challenges I encountered, the operative handling and efficiency, my IOP reduction in all these cases, and my subjective confidence which I saw improved over these cases. So, in case of my iStent, in the initial 10 cases, 9 of my 10 cases I had a correct placement, but this was under mentor supervision. And with progressive experience, almost 90% I had a correct placement, that is approximately 95%. My intraoperative challenges, which I faced particularly, were the gonio lens stabilization, controlled device deployment, and consistent visualization of the Schelm's canal. So again, from my personal view, my confidence, again, started increasing after the first case only, but definitely I saw a definite increase in my confidence after my first 10 cases, which has grown progressively after that. So each case I do, I feel like I'm learning something new, and my progress, and I guess everybody's progress will be a kind of a linear up curve, which it's very heartening, and the results also are very good. So my learning curve, I would say, mentor feedback, repeated exposure and practice has helped in my skill acquisition with an accelerated technical proficiency in devices. So this was my first iStent, which I did. So this was my first MIGS, which I ever did. This was again after a lot of wet lab practice, and this was under mentor supervision. So you can see that my visualization is not so good, and my gonioscopic placement was also a little unsteady, and the view of my Schelm's canal was coming on and off. This is a few cases later. So now you can see that my visualization has improved, and the magnification is also good. And the placement of the iStent is very good because as soon as I inject it into the Schelm's canal, there is a spurt of blood coming, which is a very good thing. However, there is still some cornea striae which can be seen. That means I'm still pressing a little bit on the cornea. Now, this was one of the cases where my iStent had been under implanted. So, as Praveen sir also shared, this has to be explanted and taken carefully outside with the help of micro forceps, and it has to be re-threaded into the trocar and then re-injected with the help of the iStent injector. So this is one of my later cases. So as you can see, the visualization has improved considerably and the magnification is also very good. My hands are now steady and the view is also very good. There's a very good dimpling of the iStent when I inject them, which indicates that the iStents are well in position and are implanted well. So, my experience, I have done around 24 cases now. So, my pre-op IOP of the patients was in the range of 18 mmHg plus minus 4 millimeters of mercury, but they were all on medication. Post-op IOP after a month's time, I saw a reduction of at least 4 millimeters of mercury. So, this is consistently which I'm being seeing in all my patients. The only drawback for me was that since I had a 1 year fellowship, I did not have a very long follow up for my patients. But as much as I could follow up, all the patients were doing well. So I would also like to stress the same conclusion as Praveen sir said, that angle-based MIGS, it requires mastery of gonioscopic visualization and precision. Surgical proficiency improves significantly within the first 10 cases. iStent Inject offers a relative easier initial handling but requires accuracy for dual stent deployment. IOP control is good. It is a safe technique, results in lowered IOP and reduced medication use. Guidance, mentorship, and repetition play a crucial role in skill acquisition, ensuring a safe and consistent outcome during the learning period. So, iStent inject can be performed safely and effectively by surgeons with a rapid improvement in confidence and consistency with effective results. This is my personal journey, my growth into a confident MIGS surgeon capable of addressing challenges and delivering the best outcome for my patients. So, just a little graph of my personal experience. My journey from a rookie to a confident iStent inject surgeon. It involves a lot of practice, a lot of practice, a lot of practice, a lot of guidance, and a lot of grit. And just a little positive quote again for my juniors who are attending. We should never forget that the small steps that we take still move us forward. Thank you, sir.
Yes, that was a wonderful demonstration of your progress through the path of minimal invasive glaucoma surgery and iStent, Dr. Aditi. So, for the
Yes.
benefit of the viewers, particularly the juniors who are planning to start iStent surgeries, so with your experience over the last 1 year or so, and you have done a fairly good number of surgeries now. So, what are the
Yes,
main
sir.
challenges that one faces in the initial few cases, and how to tackle them?
Yeah, so for sir, like sir also mentioned, that first, obviously, it's a new technique. It's a completely new technique. We never do this in our residency or, in our like nurturing years. We are not exposed to MIGS. It's a very brand new procedure. So there's a lot of stress that this is a new procedure and I have to perform. Secondly, is the gonioscopic visualization, sir, and the bimanual dexterity that we need. So one hand we have to use our gonio mirror, and the second hand we have to deploy the iStent. So this requires a lot of hand-eye coordination. So this is another challenge because I remember in my initial cases I used to place the gonioscope, and then when I'm injecting my injector, my gonioscope will again, it will shift a little, and I'll lose my view. So this is another challenge that I think everyone faces in the initial change, in the initial steps. And also, like you said, sir, that we do this procedure in a very high magnification. So even a little bit of a movement here, there, we lose our view. So that is another challenge. So yes, gonioscopic visualization is very important. And I think it's the most important, most crucial thing. Once you have a good view, then you can do anything. You just need to get that view. Once the view is mastered, then everything falls into place. But if you can't see what you're doing, then you can't inject it. So I think that is another challenge. uh, After that, the iStent has per se, I think the technique is very user friendly. The injector is also very user friendly. uh, in my initial cases, I remember I had a tendency of releasing the button very soon. So in those cases, my first iStent, it tended to be like a little under implanted. So I have a very vivid memory of my mentor kind of scolding me that don't release your button. That's a very important thing, that you just have to press the button, and if in the initial stages, you can actually inject the first iStent, press your button, don't release. If you want, come out again, inject Helon GV again, and then go, proceed for your second stent in the initial cases. So once you get that kind of memory, you get accustomed, you have that memory that you won't release the button, then it becomes easier. Then you don't tend to release the button, and the iStent is implanted in the right position. Also, as Praveen sir said, the rethreading of the iStent, that is also another challenge. And it is good if it happens in your first cases, because if it happens in your first cases, then you have the confidence ki agar aage ho jaye, I am equipped, I'll be able to manage it on my own. Other than that, before the procedure, patient counseling is very important. We have to give them realistic expectations, and the patient selection is also an important decision which we have to do. after that, as far as my experiences, all my patients have been touchwood doing well, and they're all happy. And I had done one case in recently only in Delhi. There was a patient of severe advanced glaucoma. He was actually on 4 drops with uncontrolled IOP, and his pressures were 25. So I had done his visual fields and everything, and he had a macular split in his 10-2. So I told him that, sir, you need a surgery. The ideal surgery would be a trabeculectomy, but there is a high risk of snuff out phenomena. The second option we have is a G2W. We will inject it, but you will still need to use your eye drops, but it is safer, definitely safer. In case this doesn't work, then ahead we always have the option to do a trabeculectomy. So he opted for MIGS, he opted for G2W, and he's doing very well. So he's still on 3 drugs, but his IOP is 10 after 3 months. So yes, I would also like to stress that there is a little bit of bias against MIGS, but as far as my personal experiences and what I've heard sir also talking about and my mentors, the experience is very good, and I think it is a very important surgery that is a part of the glaucoma surgeons. It's a part of us now. Every surgeon should know how to do MIGS, and every surgeon should know how to do G2W. So for my juniors also, my advice would be that when you do cataract surgeries, just practice your gonioscopy. Just do intraoperative gonioscopy so that you master your view. So you're ready for the MIGS when you have to do it.
Right, right. Thank you so much, Dr. Aditi. And
Thank you.
now, yeah. So, any questions from the attendees you'd like to ask to any of us regarding the iStent or the technique or the postoperative regimen? I think we'd be happy to answer.
Hello, can I ask a question, please?
Yes, madam.
It's like this that actually it's not a question, it's more of a comment that if a person is doing iStent, oftentimes we have seen that after some time, one of the stents gets closed by means of the iris. And therefore, if you put pilocarpine just once a day, then this thing does not occur. How long the pilocarpine needs to be put is something that I would like to ask all the panelists, if in case they know it, because we continue it almost ever since I've done it. I always put 1 drop so that at least it remains okay.
Okay. So, madam, do you use the pilocarpine in all your cases?
Yeah. In
Postoperatively?
fact, I learned this the hard way because I had done it for a lady who had bilateral advanced glaucoma with tremendously bad systemic comorbidities. She had well, I won't go into that, but she had so many comorbidities, and she did not have any household help who would help her get the medicines also. So the best would be to do something to help her out. And I found that one of her stents got blocked. Then when I was using the KDB at that time, I was told by the person who had come down to assist me, he said that, man, don't forget to put pilocarpine. And that is when the thought came to my mind that yes, pilocarpine is a very good additive because it is preventing this closure which I've seen with my iStent. So I have just continued with it. I don't put pilocarpine in when I do viscobank, but in this case, I have put yes, all cases.
Okay. So, madam, what I practice is I use pilocarpine whenever postoperative gonioscopy shows that the iris is tending to adhere or there is some close apposition of the iris with the stent and there is a chance of blockage. So, in those cases, I liberally use pilocarpine maybe initially twice a day or even thrice a day, and I gradually reduce it. And I think for 1 or 2 patients, I have been continuing for several months. But for other patients where the angle is wide open and pressure is perfectly controlled, there in most of the cases, actually, I'm not using any anti-glaucoma medication. If it is on the higher side, but angle is perfectly open and stent is in proper place, then maybe I will use one anti-glaucoma medication other than pilocarpine. But yes, if there is a tendency for the iris to occlude the stent, then definitely I would go for pilocarpine. So I'd like to hear the comments from Dr. Aditi and Dr. Preveen also.
Yeah, so sir, the case I was just describing, actually the advanced glaucoma case. The first post-op day he came to me, his pressures were very well controlled 10. Then he came to me after a month, and his pressures started rising. So I had actually gone to Sagarika ma'am, and I wanted her opinion that what should I do. So ma'am told me that you just start him on pilocarpine 1 drop. So I actually started him on pilocarpine 1 drop as ma'am advised me, and he came to me the next follow up and his pressures were magically 10 again. So yes, and I as ma'am advised, as ma'am also said, that it's not like we have to have the complete dosage, just 1 drop a day. So I'm still, he's still on pilocarpine. And I'm not I think that if he is able to tolerate it and there are no side effects, I will keep him on pilocarpine as long as the pressures are under control. But then again, it depends on the patient, I think. In cases of ocular hypertension and mild to moderate glaucomas who are doing well without, without the need of any anti-glaucoma drops, and their pressures are maintained less than 14, in those patients maybe we can just wait and watch and see if the IOP raises later on.
Right. So if the patient is otherwise doing well, if the eye stents are properly placed and the angle is wide open and without any medication, say the pressure is 12, 13, 14, then probably we can continue without any medication and do periodic examination. And very importantly, we have to do periodic gonioscopy as well for this patient. Thank you so much, madam. So any more questions? Mr. Sutanoy, anything new regarding iStent or any further updates you would like to share?
No, doctor. I think as of now there is no update from our end. So hopefully, I think we have actually now crossed more than 3,000 procedure in India, and which is in the fourth year of our launching, and we are actually increasing number of procedures day by day. With all of your supports and blessings, and this is what the our initial outcome. And also from the outcome point of view, doctor, I think most of the doctors are now preferring use pilocarpine when they find out the stent position is little bit of lower or touching the stents below flange side in the iris. That's what organization. We also started telling you that you should continue using pilo for next 15 to 20 days if you find out your stent lower portion is touching the iris. Other than this, our selecting the right patients is the key. But that's what is our request to all of you, doctor.
So just I wanted to ask Devashish sir. So am I audible, sir?
Yes, Praveen.
So about my second case, that patient was on 4 AGM with Diamox, and patient was operated elsewhere for phacotrab. And unfortunately, I couldn't see any kind of ostium, but conjunctiva was cut, and there was surgical PI, but I couldn't notice any kind of scleral ostium. So I thought that there may be some kind of mishappening during the surgery. So I planned for that patient, and I committed him. My target is to make you off Diamox. And that patient was on 4 AGM with 2 time Diamox, and the pressure with that kind of medication was 22. So after the surgery, it is now almost 10 days. So my question is whether I should stop all the AGM, topical AGM along with the Diamox on the day 1 only, and subsequently we need to start to see the response of the iStent, or we should taper the AGM from the post of day 1.
Hello?
So on day 1 we should
Yeah.
stop all the AGM and subsequently we have to step up, or from the day 1 we need to taper the AGM, then keep the patient on the minimum one.
Yeah, I think it will depend on what your pressures are on the first day. So what was the IOP, the first post-operative day?
First post-operative day was, sir, 25. So I started pilocarpine only, but on 10th day, it was 24. So I started combined drop because patient was on 4 AGM. So I started on brimonidine with timolol.
Right. I think that is the right approach. So you omit the Diamox and gradually, step by step, you can add the anti-glaucoma medication till you reach a state where the iStent has started working. Because from such a high IOP, I think it will take some time for the pressure to stabilize. So till that time, you have to tide over this phase with topical anti-glaucoma medications without causing too much of inflammation. So maybe brimonidine, timolol, pilocarpine, avoiding the PG analogs. And then once you gain a relative stability, then you can again reduce the anti-glaucoma medications to the minimum number that is required. Right. So if there are no more questions, I think we should thank Mr. Sudanoy for arranging such a nice CME, and I think we all learned some very important tips from our speakers. So over to you, Mr. Sudanoy, for conclusion of our program.
Thank you very much, Doctor. I think this is really a great event altogether. We have our eminent speakers and a moderator like you who have a vast experience of glaucoma for so many years. It's altogether have a great opportunity to interact with all of you, all of our participants, doctors who are attending today's event, and hopefully is going to attend this event in the YouTubes, which will be available tomorrow in the next few of the years to be there. So I think. Thank you very much, everyone, particularly Dr. Devashish Chakraborty, Dr. Aditi, and Dr. Preveen for taking your time out and attended a beautiful event. And all the participants, I think Dr. Sherpa is from Nepal has also joined. Thank you very much, Dr. Daki, for joining today's event. And it will be a great event altogether. I hope everybody have gained some of the knowledge, which will definitely give you the better patient's outcome in the coming days. Thank you very much and have a great night.
Thank you, sir.
Thank you. Thank you.
Thank you.
Good night. Good night. Good night.
Thank you. Good night.